They are all from the basics, like pumping blood outside the pump. So so many new things we come across today. Thank you very much. And now from cardiology, we are moving to oncology. And for that, we have Dr. Kaushal Patel. We all know Dr. Kaushal. He is an oncologist. He did his MD from BJ Medical College and DM Oncology from GCRI. And he has on his name 450 publication. 450 publication on his name. So he's really an avid researcher. And see, at present, if you look into, maximum research is going on in the field of oncology. And that's again immunology with oncology. We at Nirmal, we are doing around 120 clinical trials, and so many of them, they are on oncology and related with the immunology, monoclonal antibodies and whatnot. So this is really an interesting field. I request all of you to please listen to him. It's
some of the my personal experience which I treated with the immune therapy in advanced malignancy. So basically there are two immune systems in our body. One is innate immune system and one is adaptive immune system. The innate immune system is from birth, and the body is to a certain extent immune to some particular substance. And when they are exposed to this substance or anything foreign to the body will fight against that. That's our even normal natural resistance toward the certain things. It's non-specific and the duration of the response is very short lasting. But the adaptive immune system is very much important for us. When we expose to certain things like virus, bacteria or any foreign substance, our body will react immediately by any of the immune mechanism and try to control it or try to resist it. So it is specific towards that particular substance, either it's bacteria, virus or some foreign body. And it is to a certain extent long durations with the memory cells, we can say to a certain extent. Innate immune systems will work with the three basic systems. Granulocyte. The granulocyte is our neutrophils that envelop the microorganisms or any foreign substance and kill it. Another one is the macrophage. The macrophage is reside in almost any part of the body, and it destroys the microorganism and it also helps us to recruit some other immune cells towards that particular targets. And monocyte is to a certain extent converted into the macrophage and it works as an innate immune system parts. Now, most important part of the body is adaptive immunity. And adaptive immunity is work with the two cells, that's B cell and T cells. The B cells is specific lymphocytes and that will release the antibody in exposure to the some of the foreign substance like virus, bacteria or anything. And this antibody will come into the pictures and it will kill the or neutralize these foreign pathogens or cancer cells or any of the things which is foreign to the human body and dangerous to the human body. The T cells having three specific subclasses. T cells, cytotoxic T cells, that is the CD8 cells that will directly kill the cells which is infected by the virus or bacteria or tumor cells, and that is known as a cytotoxic T cells. Another one is the helper T cells, that is CD4 T cells, which produce the signaling proteins that's known as the cytokines. And that cytokines will activate the various cells and support the B cells to produce the antibodies. Another one is the T regulatory cells that will keep the balance between cytotoxic T cells and CD8 T cells, and it will also regulate that the body will not produce the over antibody or over immunity against any specific things. So these T cells will recognize the antigen by bindings with the specific MHC class of the antibody, and there are two classes of the MHC, 1 and 2. The 1 is present in most of the cells and it binds with the CD8 cytotoxic T cells, and MHC2 is present into the antigen presenting cells and it will bind with the CD4 T cells. So here this is the T cells will bind with the antigen presenting cells with the specific MHC class, and by which the T cell become activated and will kill tumor cells, virus or bacteria. This antigen presenting cells on which the T cells will combine by the antigen is 3 or 4 specific types. One is the macrophage, one is the B cell, one is the dendritic cells, and another is the tumor cells. Sometimes the tumor cell is also act as an antigen presenting cells to the T cell. Out of these 4 class of the cells, the dendritic cells is the most important part which act with the tumors or which act with the antigen presentation to the T cells, and immunity will come into the picture. So how these dendritic cells come into the pictures? It is immature into the peripheral tissues, either in blood or skin. Antigen, when presented to these antigen presenting cells, is migrate to the lymphatic system to the bloods and become activated, and mature dendritic cells combines with the T cells with the MHC2, and this MHC2 will activate the T cells, and this T cell will come in and do these functions by killing the cancer cells. This is our normal natural body mechanism. Now, proper T cells activations require 2 signals. Number 1 is MHC, which we have seen, and another one is the co-stimulatory bonds between the antigen presenting cells and T cells. When these 2 bindings will become active, then and then the T cell become active. So this is the first one, and this is the second one. Now, how the immune system is come when we are treating with the cancers. So this is the tumor cells which leave the tumor specific antigen inside the bloods. This tumor specific antigen goes towards the antigen presenting cells, that is most commonly the dendritic cells. And these dendritic cells will attach with the T cells with the MHC2 as well as the receptors over the T cells, and another one is the co-stimulatory bonds. These 2 bonds when become active, the T cell become active, and these T cells will later on kill the tumors by the multiple mechanisms. So the regulations between the immune systems is very much important. Either it's natural or if we provide as a treatments by the immune drugs. Too much activations will lead to the autoimmune disease and tissue damage, and too little activations will lead to the infection and activation of the cancer or ineffective treatments. So the balance between these 2 mechanisms is very, very important in our practice. And we have seen that there are the 2 bonds to be activated to T cell become active. So we have co-stimulatory bondings. The receptors on this one towards my side is the co-stimulatory molecules, and on that side is the co-inhibitory molecules. So when these co-stimulatory receptors become active, the T cell become active, and when the co-inhibitory receptors inhibited, the T cell become active. So these are some of the receptors PD1 and CTLA4 and LAG3. These are some of the inhibitory receptors on that side, and we need something to block those receptors to make the T cell active. So now we use these receptors in our practice in science to make the immune therapeutic drugs or immune therapy, in other way we can say. And these are the 3, as I said, CTLA4, PD1 and LAG3. When these 3 checkpoint molecules has to be inhibited, the T cell become active, and this T cell will kill the cancer cells by multiple mechanisms, cytokines, by activate the B cells, by antibodies, by multiple mechanisms, but it will active the cancer cells. And when the active tumor or active T cells become activated in body, it will remain for some period of the time. So once we stop the immune therapy, the mechanism of immune therapy drugs to be continued for some period of the times. Depends how much we have given to the patients. So this is the schematic diagrams. T cells and antigen presenting cells is combined with the MHC as well as the CD28. Here the CTLA4 molecules which are present over the T cells and antigen presenting cells will lead to the T cell activation. So drugs which block that CTLA4 will make the T cell activated. Simple. So we need the drugs which block the CTLA4. And same way we need the drugs which block the PD1 or PDL1, and we need the drugs which block the LAG3. And once we get this drug, which inhibit this inhibitory substance, and this active the T cells, and these T cells will kill the cancer cells. So this is PD-1, and this is how the PDR1 come into the pictures and become activated. So the anti-PD-1 monoclonal antibodies will block the PD-1 over the T cell, so the T cell become activated. So these are the tumors which can be treated with the immune therapy. Almost all of the malignancy can be treated with the immune therapy except the acute leukemia. Till now we are using the immune therapy drugs in advanced stage, that means the stage 4 disease, but now with the research ongoing we can use this drug as a neoadjuvant before the surgery and radiation therapy, and after the surgery and radiation therapy in form of the adjuvant to give the maximum possible result to the patients. These are some of my cases which has been treated with the immune therapy drugs. These are the patients having the tumors behind the sinus, behind the eyes, and this is the pictures after 2 cycles of the IU, immune therapy drugs. This is a recurrent head and neck malignancy with the significant tumors over the tongues, and it can be incurable with the surgery and radiation therapy, and after the 1 cycle patient has PCRPs with the tumors. This is a significant neck node. And after 2 cycles of the immune therapy, the patient is cured with the tumors. And this is the Ross tumors, almost incurable. After the 2 cycles of the immune therapy, almost 95% of the response with the immune therapy drugs. Out of this, the most important thing is it's a durable response. Once we give the chemotherapy, once we give the target therapy, the response will last till we give the treatments. Once we stop the treatments, the tumor will reappear. In this particular immune therapy, the response will last long durations even though we stop the treatments. And we have seen the patients after taking the treatments for 3-4 months, and patient is absolutely free from the tumor in stage 4 for almost 1 or 2 years. So the immune therapy, they can be given as a monotherapy, single agent immune therapy. Immune therapy, they can be given as a part of the combinations therapy, either with the chemotherapy, immune plus immune combination, immune plus radiation therapy, and immune plus target therapy. So it can be combined, depends upon the tumor, depends upon the patient's condition, and depends upon the some of the personal and characteristics of the patients, which decide how the treatments is ongoing, how much duration it will require, and what are the points to be taken care while treating the patients with the immune therapy drugs. If we treat the patients with the chemotherapy and TKI, that is target therapy, the duration of the response is low. We can say the last curve. If we treat the patients with the immune therapy, monotherapy, the survival is long, duration of the response is long. And if we combine the immune therapy with any other treatment aspect, then definitely the duration is maximum with this combination in stage 4 or advanced stage of the disease. So this is the how. Just briefly, and last point, the CTLA4 and PD-1 pathway targeted with the immune therapy, which is available commercially in our market, that's injectable drugs, and that will block the CTLA4 pathway. They can be used in melanoma, and we can have nowadays approval into the lung malignancy also. And the drugs which block the PDL or PD-1 has been used in number of the malignancy except acute leukemia. So I conclude my talk that the immune system per se, even in normal bodies, play a very important role to control the pathogens and tumor cells. Even without any treatment, some of the tumor disappear when it's low grade with our immune system. Immune regulation is very much important to protect our body from the autoimmunity as well as damage to the tissue. And if less, then it will provide the infection as well as the tumor will grow. The immune therapeutic or immune oncology is the new field of the cancer in which the patient will get the maximum possible result, better than chemotherapy, target therapy, radiation therapy, and surgery. It is the long-lasting duration of the response, and most importantly, that there is no any absolute significant side effects with the immune therapy drugs. The modulations of the immune checkpoint is thought to be an important mechanism in tumor cells, and that has been taken in our practice to treat the patients with the immune therapy. Thank you. And this is when first immune therapy has launched in 2018 in Taiwan, and at that moment it has been approved only in lung malignancy, and later on in 2019 has been in South Korea, it has been approved in almost all indications except acute leukemia. Thank you.
Thank you so much, Kaushal sir. for such an detailed overview about immunotherapy, because many of us don't know in details about that. Thank you so much for this. And now I would like to call upon Dr. Dipti Patel and Dr. Dharmesh Bhuptani sir to felicitate Dr. Kaushal Patel.
So it's really a wonderful talk. So we have to know about all this. This is incoming. Sir, you want to ask something? One question. Sir wants to ask.
How many immune cycles are required? And first,
Sir wants to ask how many immune cycles are required.
and what is the cost of one cycle?
And cost of one cycle.
It's a very important question actually, because the immune therapy right now we are using in advanced malignancy. So as per guideline till the progression of the disease, means or we can give it up to 1 year. The cycle is routinely repeated at every 21 days and it is injectable drugs for approximately 3 to 4 hour day care treatments. The cost of the one cycle is approximately 2 lakh at present. Because it's a research products and only one company all over the world is manufacturing it. The drugs which we are routinely using, commonly using, it's a pembrolizumab. And it is manufactured by the MSD, 200 milligram is the dosage and approximate cost of the 200 milligram is 4 lakh rupees. But the patient is, company is providing the patient assistance program, so approximate 2 lakh rupees per cycle is the cost of the therapy.
For all cancers, one drug is required.
At present, we can that the pembrolizumab has been approved in almost all malignancy except acute leukemia, so we can use in this drug. Otherwise, we have nivolumab, that is the first generation immune therapy. Pembrolizumab and atezolizumab is the second generation immune drugs. The durvalumab and dasatinib is third generation, and avelumab is fourth generation immune drugs. So depends upon the indications we are using, but pembrolizumab is most commonly used immune therapy drugs right now.
What is the interval between two cycles?
21 days.
Interval between two cycles?
21 days. 21 days. Every 3 weekly we are repeating it.
How long?
Till the progression of the disease, till the response. Approximately 1 year. Chemotherapy and immunotherapy is two different things. We can use. Explain to the patient. Explain to the patient. When the patient come to us, we generally explain them regarding the options of the treatments available with us. Chemotherapy, target therapy, and immune therapy. We explain the patients with result of all three options of the treatment, cost of the three treatments, and side effects of the treatments. And depends upon patient financial positions, they will decide. Simple. Because in India we have to look the financial position of the patient also, because out of 10 only 2 patients are eligible for the immune therapy financially. While out of 10, 10 is eligible according to the indications.
Only one injection is sufficient in one cycle?
No, one cycle is not sufficient. We have to...
One injection in one cycle?
One injection in one cycle, yes.
Can you spell the drug that you spoke?
Sorry?
Can you spell the drug?
Spelling?
Pembrolizumab, P-E, Pembro, P-M-B-R-O. Pembrolizumab, L-I-Z-U-M.
L-I?
So, Z-U-M, Z. It's a monoclonal antibody.
Monoclonal.
Sir, Kaushal bhai, do you for which type of CA lungs you suggest this type of immunotherapy, and especially for which staging? Does immunotherapy has a relation to the staging of the patient?
Yes. Till now we are using in stage 4 disease. But nowadays we have data to use in neoadjuvant before the surgery or radiation therapy, after the radiation therapy also. And it has very wonderful effects, particularly the first malignancy in which we have used the immune therapy is the lung malignancy. In stage 4 cancer, we can use immune therapy mono when the PD-L1 score over the biopsy is more than 20%. We can use we can use immune therapy with combination of the chemotherapy if the PD-L1 score is 0 or not done. And in these two indications, the patient has to be negative for the EGFR and ALK. That is the two biomarkers which can be treated with the other targeted therapies.
Or any correlation of the result of immunotherapy with the type of CLM?
No, it depends upon PDL1. If the PDL1 is more, the response is more. Fine. Thank you very much.
Thank you. So, I feel, see, it's all monoclonal antibodies, and monoclonal antibodies are taking over the medical field as a whole. You take any medical field and monoclonal antibody is there. Of late, we are treating hemophilia patients with blood plasma, and now monoclonal antibody single dose and bleeding stops. And it's like coming like anything in all the fields. So we have to now remember everything. This B cell and T cell and macrophage, immunological system and where it acts. Even if we want or we don't want, then we have to teach in medical colleges also all these things. So thank you, Kaushal. Thank you for enlightening on this. And now,
It won't suppress the immunity.
no, it will not. So rather it's a monoclonal antibodies. It helps. So now we move on to the another equally important field. New one. See, my sister-in-law, she came from US and she brought robotic cleaner. Our civil hospital got 2 robots from L&T during the time of COVID just to serve the patient that food. Similarly, all the fields robots are coming up, and we as a medical personnel, we have robots in our own field, and for that, to know us about the robots in knee replacement, we have with us Dr. Shyam Nadange. He is a consultant orthopedic surgeon and joint replacement surgeon at Sir Harkishan Das Hospital, Reliance Hospital, Mumbai. He did his fellowship in joint replacement, sports injury and arthroscopy from Brazil and Spain, and he has a vast experience of joint replacement surgery at Shelby Hospital, Ahmedabad. With this, I request Dr. Shyam to deliver his talk on another important